So usually we start right around 12:04, 12:05.
Okay.
We'll join.
And I have the slide set. Am I good to share my screen?
Yes, you should be
Okay.
fine to go. You can go ahead and try that if you want.
Okay.
All right, great. I think we just reached our rapid join and got our usual core group here. So today we're going to have one of the 31st annual conference in HIV and Hep C. And today's session is going to be hepatitis cases moderated by Sherilyn Brinkley, Lee Gillum, and Juhi Moon, and Mark Sulkowski. I also just want to remind people that next week, actually, the conference it will be canceled because there's a ID town hall meeting. And then the following week, we have Chris Hoffman coming to talk to us about cognitive load and decision making, which should be really interesting. And with that, I will turn it over to the hepatitis team.
Thanks so much, Eileen. Great, thanks for joining us, everybody, on this wonderful Friday. So today, Sherilyn and I are going to be discussing cases, and our esteemed panel of Lee Gilman and Dr. Mark Sulkowski will weigh in with their opinions and thoughts. We don't have any audience participation in terms of selecting the answers, but if you certainly have questions or comments, please let me know. I believe there was a CME code and I had texted it. 38. Great. So again, if you have any questions, please don't hesitate to just chime in. You can raise your hand or you can just unmute yourself and chat. We want to keep this an open discussion if there's any questions. So first we're going to start, we're going to talk a lot about Hep C cases, which I'm sure you all expected, but we're also going to talk about hepatitis B, and this case is going to be about hepatitis D. This patient is a 34-year-old male from Romania. He tested in the setting of subacute symptoms of lightheadedness and fatigue and elevated ALT and AST. He was diagnosed with the hepatitis B surface antigen that was positive and hepatitis D delta antibody that was positive in Romania 4 years ago. He took interferon injections once a week for 6 months in 2018 or maybe 2019, and said there was no effect of the interferon on his infections. The most recent labs we have are from November 2021. His hepatitis B E antigen is positive. Hepatitis B DNA or viral load is 434 international units. Hepatitis D RNA qualitative was positive, but the quantitative could not be run. In terms of his liver staging, he had a serum fibrosis panel that was F2, FibroScan of F4, moderate hepatic steatosis, AST of 41, ALT of 60, bilirubin 1.3, albumin 4.7, INR of 1.1, and platelets of 120,000. He was negative for Hep C and HIV. So I just want to ask, in terms of our panel, there's a lot in this vignette about this patient. He's 34, Hep B and Hep Delta. We have a viral load of 434. LFTs are moderately elevated, and his liver staging shows potentially F2, but as serious as F4. And just thrown in for this patient is he's got Hep Delta. So Lee, if you had this patient in your clinic, and this was kind of all the information that you had, what would you do in terms of, first, I just want to ask you about liver staging. How would you stage this patient? How severe is their liver damage?
Yeah, that's a really good question, because there is sort of a little bit of divergent information here. The serum fibrosis panel was F2. The FibroScan suggests even more significant damage. I actually with disclosure, this is my patient that I did see in the clinic. But upon Mark Sulkowski's recommendation, I actually reached out to the hepatitis D, like the foremost hepatitis D expert at the NIH, Dr. Christopher Coe, and actually asked him about this, and his response was that he thought it was probably closer to F2 than to F4 for a couple of reasons. One is that hepatitis D or delta tends to have a pretty significant inflammatory component, which could artificially raise the FibroScan results. And then also he was somewhat reassured that the albumin was still 4.7, and that the AST and the ALT had not reverted back to a normal, sort of a more in normal range, which tends to occur in more, sort of for more progressed cirrhosis. So based on that, sort of, I would assume that the staging is probably closer to F2 or F3 than cirrhosis. The other thing too is he had denied having any episodes that were suggestive of decompensation.
Okay.
Yeah.
Great. Yeah, and the question of the staging really plays into, my next question, is would you treat him? A lot of our Hep B guidelines are not only about viral loads and liver function tests, but also liver staging. If he had cirrhosis, you would certainly want to treat, but it's now saying that he's probably closer to F2. How did you go about thinking about treatment? Did you treat his Hep B, or were you more concerned about the Hep D? How did you go about your treatment choices?
Yeah, so it's a little bit of a also it's complicated. We don't really have any particularly effective medications available right now for hepatitis D. Interferon is sort of the only one that is available, and sustained virologic response rates are more closer to around 25%, which isn't really that great. And I think we'll talk about this in a little bit, but there is a medication that is monotherapy for treatment of hepatitis D or delta.
Yeah, I can move to the next slide.
Okay, yeah, and it has been approved, or it's been approved in Europe for under emergency use authorization, and is available in Germany, Austria, and France. It's called bulevirtide, or Hepcludex is the brand name of it. But and it's been submitted for FDA approval, but has not yet been approved. So hopefully that is in the pipeline sometime soon. In discussion with the patient, we did decide to start the patient on entecavir to treat his Hep B, in part to try to reduce some of the viral replication and reduce sort of more rapid progression of his liver disease, which tends to occur more rapidly with hepatitis delta co-infection anyway. And also because I didn't really have any other options for treating his hepatitis D at the moment. There was also the hope that by treating his hepatitis B, possibly it might improve some of his just day-to-day symptoms of fatigue, and he was also experiencing mild nausea too. And we started him on entecavir rather than TDF or TAF solely out of cost consideration. He's uninsured, actually lives in a different state, and would drive halfway across the country to the visits to see me. It was a more reasonable, entecavir was more reasonably priced on, with a good RX coupon. And then the other thing, and it's on this slide as well, but the other thing too is that I did attempt to connect him to an investigational protocol at the NIH too. Yeah.
Do you know if he made it, or did he transfer over to their care? I don't remember.
He did not successfully engage in their care, and that actually had more to do with communication barriers. There was no direct phone number that I or he was given to call, and he, he's monolingual, Romanian speaking, and we used an interpreter during our visits, but I think there was still some communication barriers there. The other thing too is he has no email address, and no one in his family has an email address. They sort of use WhatsApp and the phone, and so there wasn't really a good way to sort of pass along information back and forth, unfortunately.
Gosh.
Yeah.
So this is kind of a case on hold.
Yeah.
And there is recommended baseline ultrasound screening that we need to do for cancer screening. And this is more along the lines because of the hepatitis B diagnosis, rather than any particular liver staging guidelines. As we all know, patients with cirrhosis get routine ultrasound screening for liver cancer. His screening is also for liver cancer, but due to his Hep B diagnosis. So yeah, this was a complicated patient for sure. But just,
I wonder if it's worth. Oh, sorry.
No, go ahead, Dr. Sulkowski.
Oh, I just wonder if it's worth backing up a little bit and just talking about D, because I feel like it's something we haven't talked about a lot,
Yeah.
It's I think if we took a show of hands, number of people who have diagnosed a person with HDV in the Bartlett practice or in Baltimore, it's not that many, but yet people with HIV are one of the groups that is at higher risk and higher prevalence. So it's a group where actually HDV screening is recommended. So everyone who's S antigen positive is recommended to have a D antibody. And I'm curious as to how often that's happening.
Yeah, I don't think we know that at this time. I know I just started doing it just a couple years ago, but I hadn't been routinely checking everybody who had Hep B for Delta.
I mean, I can only speak for myself, sorry, that, I've done it and then I just didn't really know what to do with it, Mark. So,
yeah.
So, I mean, it's recommended, but then it doesn't sound like you can do a lot with it. Yeah. And so, I don't know, like, it just feels like I would give the patient another diagnosis and then, what does that mean for them? So.
That's a great point. And, I think one of the issues is that generally people get D in this population, get D on top of B, and then they have a super infection with a more aggressive course of disease. So perhaps monitoring more, but it's also just worth noting that I see Chloe, I'll defer to her to talk about the, how the fact that the nukes don't do anything against D, and but there is interferon, which heavens knows I don't miss from the Hep C days, but it is not FDA approved, but it is recommended. Anyway, I see Chloe's camera's on, so I'll stop talking.
So there are a couple of things about this case that I think that are interesting that I just wanted to make sure that people realize. So first of all, like Mark said, I think most people don't know that much about hepatitis D. And I think that for your purposes, one of the important things to know is that the hepatitis D actually uses the hepatitis B surface antigen as its envelope. So it doesn't actually make its own envelope. So it actually enters the liver the same way as hepatitis B does. So there are some studies that have looked at, well, if you give entecavir or tenofovir and reduce the amount of hepatitis B, and will that then reduce the amount of surface antigen and help the hepatitis D? The bottom line is it doesn't really significantly help the hepatitis D, and that's probably because where the nucleosides work on inhibiting the reverse transcriptase, it has nothing to do with really how much surface antigen is produced. And as some of you may know, people produce way much more surface antigen than actually gets packaged into virion. So we're not really reducing surface antigen to any degree, which is probably the reason that giving the nukes doesn't really help. I think the other really interesting thing about this case is that if you go back to the slide before, Juhi, he is e antigen positive. Yeah, so he is e antigen positive, but his hepatitis B DNA is only 434. And so for us that treat a lot of hepatitis B, those don't, there's a disconnect there. Usually with e antigen positivity, your hepatitis B DNA levels are really high. But when you have hepatitis D, actually, your hepatitis B does go down. And I don't think that people know for sure why that is, but my best guess is that hepatitis B doesn't generate, it's called the stealth virus because it doesn't generate much of an innate immune response. You don't get much interferon production. But with hepatitis D, you actually do get that interferon production. And so probably that interferon is reducing the amount of hepatitis B that's there. But so if you see a patient that's e antigen positive and their DNA levels are so low, even if you don't normally check hepatitis D, you should think, well, there's something going on here that doesn't make sense. And checking hepatitis D would be a good thing to do in that situation. I think that's all I wanted to say.
That's great. Yeah, there's a lot in this case for sure.
If you go to slide, I think it's slide 20 in our presentation, that it sort of has an overview of really who we would absolutely recommend, or not absolutely, but who we would recommend being screened for hepatitis.
Yeah. So this is the screening that Lee was alluding to. Hep D co-infection is in about 5% of people with chronic Hep B, with hotspots in Western Central Africa, Mongolia, Moldova. And the screening recommendations, according to EASL, is that all Hep B surface antigen positive persons should be screened. And AASLD guidelines are more along the lines of those who are at risk. And the at-risk populations are on the right. So persons born in regions with high Hep Delta, and they name many countries and regions, but more, I think, related to our current day-to-day practice is persons who have ever injected drugs, MSM, individuals infected with Hep C or HIV, those with multiple sexual partners or any history of STDs, and individuals with elevated ALT or AST with lower undetectable Hep B viral loads, which would have been our case, our patient all the way at the bottom. So these are the screening guidelines.
Yeah, and it's worth, there is an active debate about the AASLD guidelines that are, complicated, the at-risk versus the European approach, which is everybody. And I suspect that at least in clinical practice, we're going to move towards a screen everybody. We're already there for people with HIV. And that's because the drug that Lee mentioned, belveritide, is at the FDA right now with perhaps an approval, which would answer the question that Joyce raised. Well, what do we do about it? Because interferon is so limited. Well, we hope in the next 6 months we'll have something that we can do about it with a drug that is a subcutaneous injection daily, but has had benefit in lowering HDV, RNA, ALT levels in people, but very few side effects as well. It works by blocking the receptor for the Hep B surface antigen. But anyway, so it's one of these things that I think is going to get looked at quite heavily over the next year.
Excellent.
I just wanted to comment too on Joyce's point in that we actually have a mutual patient, and this is someone with chronic Hep B and Delta, had a history of Hep C, took interferon, but has had very aggressive liver disease, so is cirrhotic. And, it's one of those things where you do scratch your head and you think, okay, what else can I do? You can eliminate the Hep C, you can control the Hep B, but that Delta really is a thorn in your side, not knowing what to do. The other issue with this patient, as well as the patient in this particular case, is, the liver fat. So, trying to do everything you can to modify those other risk factors for progressive disease, is sort of what we work on with the patient. And so sort of one of the things that we've worked on with our mutual patient in Bartlett is, just trying to work on this fatty liver scenario as well. But it is a bit unsatisfying knowing that you've got somebody with Delta and he was intolerant to interferon years ago. So that makes it, less of an option in his case.
Excellent discussion. So we're just going to move on to the next case. Sherilyn, do you want to take this one?
Sure, yes. So this is a 71-year-old Burmese woman with chronic hepatitis C genotype 3, and she tested positive in January of 2021, actually, in the setting of elevated liver enzymes and abdominal pain. So she was seen by an outside gastroenterologist who did the full workup, and interestingly enough, it did include a liver biopsy in March of 2021, confirming stage 3 to 4 fibrosis, or sort of early cirrhosis with incomplete bridging and benign liver mass. So at that point, she was treated with sofosbuvir velpatasvir for 12 weeks. So this started in March and concluded in June. However, in the middle of treatment, there was a communication error that caused a gap of 2 weeks in the treatment. So after 8 weeks of treatment, she had this gap in actually getting access to medication, because payers, have often required a week 4 viral load when you're on a 12-week regimen to allow that final dispensation of medication, that final month. So in this case, that week 4 viral load was not submitted. Therefore, the patient had a delay in accessing that final month of treatment. But it is noted here that when she had her meds in hand, she was 100% adherent. So she was on top of taking her medication. Unfortunately, she stopped treatment and she had a prompt virologic rebound. So she was a treatment failure. So at that point, the provider did not move forward with completing the prior authorization for what would have been the next step in treatment, which is a combination of sofosbuvir, velpatasvir, oxalaprovir. So she ultimately came to Bartlett seeking care for her Hep C. She had a workup in March, and at this point it consisted of a fibrosis panel, so fibrosis markers showing stage 4 fibrosis or cirrhosis. She also had a fiber scan, and interestingly enough, the fiber scan showed a result of 10.1, so sort of borderline stage 3, not confirmed stage 4. Usually you're looking for something 12.5 or higher on the fiber scan to confirm cirrhosis. And you can see her AST is elevated to 60, higher than the ALT of 39. Total bili was 1.7. Albumin is within normal limits of 4.3. Alk Phos 129. Platelet count is good at 184, and her INR is 1.13. No prior decompensating events. She's considered a compensated cirrhotic with, which is an important criteria when you're looking at treatment options. I guess I would be curious, just from the panelists around this initial liver biopsy that was conducted. Do we know in this case, if the biopsy was done because we were looking to sort out liver mass, or was this done to actually look at liver tissue and stage the Hep C related disease?
It was done to evaluate the liver mass.
Okay.
Yeah,
it's just an important point, because we don't, as most of you know, we don't typically do biopsies for straightforward Hep C, and it is nice that we have other modalities here to sort of determine the degree of liver fibrosis. So it's a little atypical to see that.
It's interesting to think about it. The approach at Hopkins generally is, if the MRI, they feel very confident in their ability to distinguish hepatocellular carcinoma from benign regenerative nodules by MRI. So it's interesting that I haven't had many patients go down the biopsy route for biopsy. And maybe it's just a difference of, sort of comfort level with that.
I've had another patient who also had a liver mass. That this was in a rural part of the state, and the local specialist recommended biopsy as well, as sort of the next step. go to the next slide.
So Stuart was asking about why, since was there any fat on the biopsy? Because steatosis has been linked to genotype 3. We haven't, so curious about that.
I don't know that we have that information, but it's a good point. So in her case, if you go to the guidelines, what was recommended was sofosbuvir, velpatasvir, voxilatravir plus ribavirin. And this is specific to patients with prior treatment failure with genotype 3 infection. So a little bit different that we have ribavirin re-entering the stage here where we thought we'd gotten away from ribavirin. So that's guidance around sort of her next treatment option. What are your thoughts around, I'm curious, Juhi, I mean, you used a lot of ribavirin back in the day, but what are your thoughts around the use of ribavirin in a patient who's 71 female?
Yeah, I think it would definitely matter what the baseline hemoglobin is. We see that hemoglobins can drop. I've noticed about into 12 weeks, maybe about 2-3 points in patients. So if her hemoglobin is a lot higher, then she probably would be able to tolerate it. At the same time, sometimes we do dose reduce if patients are more anemic, and there are a lot of cases where you can't use ribavirin altogether because of the anemia, and you have to extend your treatment. It makes it difficult because she has cirrhosis and genotype 3, both difficult on their own, but together make it even more difficult to achieve an SVR, which is why we need the ribavirin. If she wasn't genotype 3, you wouldn't need the ribavirin. If she wasn't genotype 3 with cirrhosis, you wouldn't need the ribavirin. You would just do Sofl-Vox alone, and that would be sufficient. So I would at least try and see if I could get some in and see if she could tolerate it.
What do you do in terms of monitoring? How often would you?
Yeah, if someone's on ribavirin, I usually check their hemoglobin every 2 weeks and follow from there.
There's a couple additional points with her in her case is that she also has frequent gastroesophageal reflux disease. So she has frequent episodes. So she's working to moderate that with just, watching trigger foods, not eating late at night, et cetera. She does take famotidine with her Hep C medication. And so just acknowledging that there can in some cases be, drug interactions that we need to consider with Hep C therapies and acid reducers. So that is something that, particularly in this case, where you're really looking to get maximum medication concentrations and really, sort of eliminate this Hep C this time, you want to make sure that you're paying close attention to those variables as well. And it says here yellow treatment group. I'm curious. I think it's worth bringing that to the attention of everyone attending today, just to what that means and reminding folks of kind of the amazing support that we do have in our program. Lee, do you want to speak to that?
Sure, yeah. So we, the viral hepatitis team has developed a stoplight approach to sort of coding the wraparound services that we try to provide and support patients with. And so green, green is, they're pretty good to go, and we probably will follow up with them about, just once a month throughout treatment after an initial visit and initial consultation. Yellow is obviously somewhere in between, but in general with the yellow treatment group, it usually involves a phone call from our nurse, usually about once a week. It also involves like pretty extensive pre-treatment counseling by either the provider and or the nurse, and then also the pharmacist. Often the pharmacist will check in at some point during the visit, and our pharmacy team is really on top of it with making sure that they receive their refills on time. And then the red treatment group is people who were pretty worried about their their adherence based on, their past history of taking medicines, possibly other forms of instability in their life. And for those people, we may see them every 2 to 4 weeks, definitely have a weekly phone call with the nurse, and just sort of a lot more support and follow-up. So for this patient, even though they're in the yellow treatment group, we are having them get, as Julie mentioned, checking their CBC and CMP every 2 weeks during treatment, just to monitor their hemoglobin and testing. Yeah.
But I wonder if I could mention Lee, thanks for going through that. I think it's something that was put together that Sherilyn had really pioneered back in, along with our colleagues in pharmacy back in, 2014, 2015. It really has stood up over the test of time. But there's an interesting study that Sunil Solomon led through the ACTG called the Min-Mon study, where it was sort of the ultra green group. The people got 84 tablets of Sofvel, some basic lab work, and then they came back 24 weeks later, and the cure rate was 95%, similar to what we expect, and people with HIV did just fine. So it was the kind of complete opposite. It was just sort of, here's your medicine, it's safe to take, go do it, no labs, no visits, and it was done in 5 different countries, including the Bartlett Clinic. There were 5 people enrolled in Bartlett. So it's just interesting how tailoring from all the way to the red to the sort of what I'll call bright green, where you're just really just giving them treatment and trying to figure out who's right for what. Because in that study, younger people actually didn't do so well, people under the age of 30, with the sort of, here's your medicine. Anyway, interesting study that Sunil recently published in Lancet GI Hepatology. And I don't see him on, but anyway.
Yeah, thank you. That's a great comparison, because I think, we do sometimes get a little over cautious and with some patients when they do beautifully, if left to their own devices, they're highly successful. And sometimes we get it really, we get it right when we try to determine a person's level of adherence, and sometimes we don't. But I feel very fortunate that we do have the support services in Bartlett that we have when we feel like we need them. And certainly we want to see patients. Sometimes we get referrals from oncology and other services because they know that we have that extra support, and they know that we're set up to help our patients succeed. So the final sort of teaching point I wanted to point out in this case is, so this patient, while her FibroScan was 10.1, she did have fibrosis markers showing cirrhosis and a biopsy as well. And so I guess the thing, to point out here is, what do we do about this EGD issue? Because she does have a history of reflux, but is she someone that we actually need to screen for varices based on what we know about her liver disease?
Yeah, I'll take that one. In terms of the screening, how we do our staging, most of the time we don't have the benefit of biopsies. We're using fibrosis panels and FibroScans. And we have pretty clear data about FibroScans helping us determine who needs EGD and who doesn't. We know that as the score gets higher, there's increase in the hepatic venous pressure gradient. And so therefore there's more complications of cirrhosis that can be expected, including esophageal varices. So the recommendation currently is those with preserved platelets, which means greater than 150,000, and a FibroScan score of less than 21. In those patients, you can actually avoid doing endoscopy. So this would be someone you probably should repeat FibroScans on yearly to make sure that they're really sticking around that 10, or is she progressing? But we can use a FibroScan and platelets to avoid getting EGDs in a lot of our patients, which makes it a little more beneficial than a FibroSure alone, which was the liver fibrosis panel.
Great, thank you, Judy.
The only other thing I wanted to point out, since we're talking about FibroScan, is Lee, thanks for pointing out in the chat that the CAP score was 214. So a lot of folks may not know exactly what that means. When you do get your fibro score, you'll see a fibrosis score on there. I'm sorry, something's happening to my mouse. You'll see a fibrosis score on there on the right, and on the left will be another score called a controlled attenuation parameter, which is the CAP score, which measures steatosis, so the amount of fat in the liver. And we have different cutoffs, and you'll see it in the report, but generally if you're less than 240, there's no steatosis. More than 290 decibels per meter, it means at least a third of the liver may have fat in it. So the cutoff is 66% of steatosis is present in the liver if it's more than 290. So these are kind of rough cutoffs because there's a lot of different studies on CAP scores using different populations. So these are very rough cutoffs, but it's at least helpful to know in patients who you've already treated their Hep C or you've controlled their Hep B and you expect those liver tests now to be within normal limits, but perhaps they're hovering above normal or they're still showing some liver inflammation. If you look at the CAP score and see if they do have a significant amount of steatosis, you could potentially be thinking about whether the patient has NASH. Although we do know that diagnosis has to happen through liver biopsy, but just for you to use the CAP score in your day-to-day practice, it is helpful.
Judy, thanks for walking through the CAP score. I also wanted to just mention that, so there's two things that can cause liver fat. One is alcohol-related liver disease, and the other is non-alcohol-related liver disease. And they tend to look the same on FibroScan. You can't tell the difference, and they tend to look pretty similar on liver biopsy. But I wanted to point out that I think it's in a couple of weeks, maybe a month or so, Victor Chen is going to come and talk about alcohol-related liver disease in our patient population. So that's forthcoming. But also just make a plug for if you do have a person where the liver tests aren't normal and you've looked for the usual suspects, hepatitis C, hepatitis B, think about metabolic related liver disease, and a FibroScan can be very helpful. It'll give you both an idea of stiffness, but also a hint of whether fatty liver might be the cause. So that's a great next step in terms of evaluating an abnormal liver test, because the ALT and AST really should be in the normal range in a healthy person with HIV.
Excellent. So we'll move on to the next case. This is a patient with Hep C and lymphoma. So 63-year-old male with genotype 1A and B-cell lymphoma. His prior treatment history in 2021, he took maybe a month of treatment, not really sure what it was for his Hep C. He had some leg swelling, which he thought was related to medication. He stopped taking the medication and just fell out of care. He developed scrotal and lower extremity edema with his lymphoma diagnosis and lymphadenopathy. And this was connected and he was connected to us while he was hospitalized inpatient for the oncology treatment course. He has a long history of illicit opioid use. He uses a few times per week for chronic pain. His pretreatment labs, on his first assessment, he has a fibrosis score of 0.65, which correlates with F3 disease, AST of 38, ALT 19, total bili of 0.5, albumin of 3.7, alk phos is 105, T protein, total protein is 5.9, platelets of 290,000. In terms of his serologies, he's Hep B surface antigen negative and surface antibody negative, so he does need to be vaccinated. He has a core antibody that's negative and a Hep A antibody that's also negative. So I think in terms of treatment, so Lee, for this patient who has lymphoma and Hep C, and you've done a preliminary workup, what would be your potential options to treat him with? And would you treat him now, or would you wait for his oncology treatment to be completed, or them to have a plan? How would you go about his Hep C treatment? How would you time it, and what would you use?
So for, no matter what, I would always communicate with his oncology team to sort of formulate a plan together. In this case, the oncology team actually reached out to us and presented, I wasn't aware of this, but some studies that actually suggested that with his type of B-cell lymphoma, that there have been some case reports where concomitant treatment of the hepatitis C virus could actually improve sort of both the success of treatment of his lymphoma, but then also in terms of symptom control and the ability to tolerate his chemo. So for this individual, the oncology team reached out to us and requested that we start as soon as possible. So we were able to coordinate and get all the labs that we needed to do. We weren't able to do a pre-treatment fiber scan because he was inpatient hospitalized. I guess we could have requested an ultrasound with liver elastography to have been done prior to treatment, but we didn't end up doing that. And because even though we don't have all of his records, because he is treatment experienced, the soft box is really the best option. We don't need to add, based on the guidelines, we really don't need to add ribavirin in his case because he's not genotype 3. And so we were able to start his, we were able to apply for prior authorization, get approval. Our nurse went up in patient and went over all patient education and medication education with him, and we were able to start him. Since he, we put him in our red treatment group for really close follow-up, because he had a history of falling out of care in the middle of treatment, because also given his history of illicit opioid use, just wanting to sort of keep a close
second option, and probably one of the final options, which is Sulkowski, which is very effective. And so regardless of not knowing what we took in the past, and we are using Sulkowski because you don't need any resistance testing. He's not a genotype 3 patient, so any resistance that he may have acquired during treatment or prior to his other treatment is really null and void. When you're using Sulkowski, it's very, very effective. So I'll move on to our next case.
But Judy, I was just going to say that
Yeah.
I must say that sometimes in patients like that, I have sent NS5A resistance testing, but it's wild type. I've kind of recycled the old regimen, only because the PI voxelopiravir does add a little bit more in terms of drug interactions, and I wonder if that's I guess I was going to ask Lee how do you feel? I've debated this a fair number of times. In fact, I had a guy recently who claimed to have taken a full course of lead soft, but we checked the pharmacy records and there wasn't any. So we ended up giving him his old treatment and it worked. But anyway, I'm wondering how you decided, what do you think about that discussion with these partially treated people? It took a month or so.
Yeah, I mean, I think that is a really good question. I think part of the reason for choosing the soft Vox was expediency, that we would, and sort of the soft Vox is generally very easily approved for people who have a history of treatment experience. The resistance testing could take a number of days to return, and then we would have to also submit a prior auth. So I think in this case it was the expediency that sort of won out. I do have another patient who was treated with sofosbuvir velpatasvir while incarcerated, had treatment success, has been reinfected, and I wanted to retreat him with the same medication that he had previously been treated with. And that has actually been denied, and the appeal has been denied by his insurance company. Yeah, so
a safer, quicker option. Safer because you're going to cover it if he did in fact fail, and
Yeah.
quicker because you don't have to wrestle with insurance.
right.
All right, you convinced me.
Yeah, I mean, you would probably go down the road of like a peer-to-peer eventually in about maybe a month to 6 weeks,
Right. Yeah.
and you could fail. Yeah. All right. All right. Sherilyn, do you want to take this one?
Yeah, thank you. So we have a 64-year-old man with a history of Hep C genotype 1 infection, history of opioid use disorder and remission for many years. And in 2016, he was prescribed ledipasvir sofosbuvir and was successfully treated. So he achieved a sustained virologic response. Before treatment, he had a serum fibrosis panel showing stage 2 to 3 fibrosis, so moderate to severe disease, and also had a FibroScan that was 7, which really suggests quite mild fibrosis. So a question for the panel: how would you monitor him after achieving SVR? So he's at that point, Hep C completely eliminated. So how do you approach follow-up? Number 1, liver ultrasound every 6 months. Number 2, liver ultrasound plus a serum AFP every 6 months. Number 3, Hep C viral load every year. Number 4, liver fibrosis panel or FibroScan annually. Or number 5, no monitoring required. Who wants to take it? Lee?
Sure. Yeah. So since he achieved SVR, and his pre SVR liver fibrosis is not really suggestive of cirrhosis. There's no there would be not really any indication for continuing hepatocellular carcinoma screening, whether through AFP or liver ultrasound. It would be reasonable if he has ongoing risk factors for reinfection with hepatitis C. For instance, if he were to relapse to opioid use, that would be an indication to recheck his hepatitis C RNA level for reinfection. However, sounds like he's been in remission for many years, so that is not something that needs to be monitored annually either. And then I would say number 5, no monitoring required.
Agreed.
If we go to the next slide, the plot thickens a bit. So Hep C clinician says you don't need to be monitored, nothing specific, but he comes back in 2022 because his primary care provider informed him he had a touch of hepatitis C. So his Hep C RNA was less than 15, but target detected. So he had a qualitative RNA that was positive. So let's go to the next slide. What action do you advise at this point? So number 1, are you going to initiate a prior authorization for Hep C treatment? Are you going to order a urine toxicology screen, or repeat his Hep C viral load, HCV RNA? Initiate liver cancer surveillance with liver ultrasound, or number 5, repeat liver disease staging. All right, Juhi, what do you think?
Yeah, so I think first, it's difficult to know what, touch of Hep C really means. I would probably repeat this viral load to see if it's truly he has Hep C or not. He may have gotten reinfected. That's always a possibility, and he could actually be clearing the virus on his own. Up to a fourth of patients can actually do it on their own without any treatment required, and he is less than 15, even though it says target detective. So I would probably repeat the testing. I think prior auth and liver staging, cancer surveillance can be done once you've determined if he truly has Hep C. And then you can go down the route of getting your staging and a prior auth for treatment. And if he's indeed cirrhotic, then doing cancer screening. I think I would first delineate truly if he still has Hep C or has he cleared that. A urine tox screen would be helpful in the moment if we thought that he was using again, but we don't really have that information of how recently he's been using. So I probably, if of all the choices, I would repeat his Hep C RNA testing and see if he truly still has it, requires treatment.
I'm curious from the panelists in general, just show of hands, how many of you had a patient like this where they come back with known cure, but they come back with this urgent need to, of new Hep C because they have a qualitative RNA that's positive, but a quant that's negative?
Yeah, I'd say two scenarios though. Sometimes they order the antibody and the antibody comes back positive. And in this case, it was the RNA that came back. It's actually a real patient, and the consult really did say a touch of Hep C.
Nice.
But it's, anytime they're that low, I agree with Juhi's suspicion. Typically this virus, unless they're perhaps clearing acute infection, replicates rather prolifically. So I'm a little suspicious anytime I see these and think about false positives.
Yeah, I agree. I think we've all had these scenarios come into our practice at some point. So repeating that viral load and just reassuring patients oftentimes. A lot of education at our, what we call our cure visits around informing patients you never need a Hep C antibody test again. And, if by chance someone orders that, it will always be positive, and that can create confusion. So we try to do a lot of counseling around those points to avoid these scenarios where people come in quite anxious thinking they have Hep C again. So final workup shows he does not have Hep C RNA and his serum ALT is 29. He did have a liver fibrosis panel, which came back stage 1 fibrosis. Any recommendations from here in terms of additional follow-up that you would recommend for this individual?
I guess I would go back and find out why he was tested to begin with. Was he concerned that he was reinfected? Are there any practices that put him at risk for ongoing infection? I'd probably have that dialogue with the patient to see if he is actually someone who warrants routine screening for Hep C.
That's a good point. Yeah, I think one of the things that that is important to understand about long-term follow-up in patients that have been successfully treated, if we go to the guidelines, there are populations where we would continue to monitor their HCV RNA. If they're at risk of reinfection, we want to make sure that we're capturing that. But then there's also a cohort of patients that once they're treated and they're cured and we've confirmed that, we often will send them on their merry way if they don't qualify for ongoing monitoring or repeat viral load testing. So it's just something to, we put that in our clinic notes, but sometimes some people feel compelled to continue to check HCV RNAs when it may not necessarily be indicated for an individual long term. So I think, Juhi, we're almost at time. I wonder if we should conclude with that final case. Any questions? I don't know. I didn't see any come through in the chat specifically that needed to be addressed. No.
Can I take 30 seconds to make a plug for our HIV fatty liver disease study? We have a cohort funded by an NIH grant to look at liver fat in people with HIV. And we're really actually want to just look at everyone to try to understand the true prevalence and what's associated with it. So it includes a FibroScan. So I'll make a plug for that. We are taking referrals, and it's about a 2-hour visit plus the FibroScan.
Mark, how do you refer to that? Should they stop by the research desk, or just because one of the gaps is that we think, oh yeah, and then we don't do it in the moment.
Yep,
so.
Absolutely. If they're in the clinic, stop by the research desk. If they're if it's a asynchronous referral, you can just shoot myself or an email, or Cheryl an email. We're happy to connect them to coordinate.
Dr. Bassett's actually CC'd me some charts, like that she's spoken to the patients and they've agreed to participate. And she just routes me the chart, and then I link them to one of our coordinators to get them in.
Great. And
That's
should we just
easier.
put a statement in the note that patient has agreed to be contacted or something?
Yeah, yeah.
Perfect.
That's
So
what
anybody
she
who's
says.
on the call, HIV patient screening for fatty liver disease, please try to think about those things so we can learn more to help our patients. Thank you all so much. This was fantastic. I know I learned a lot, and I will try to not just code with or without hepatitis B, but actually test for it. and looking forward to the next session. So the next liver session is indeed July 15th. And then it'll be Dr. Victor Chen and Dr. Schoenfellade talking about alcoholic liver disease and opiate use disorder in the management of patients with hepatitis. So thank you all so much, and everybody have a great weekend.
Thank
Thank you
you.
all.
Bye.